Right. Sorry about that. That was some technical glitch. Okay. So in your consultation is basically in step one, in which your patient tells you a story and you organize it in your head, use your clinical knowledge, medical knowledge, sort it out, join the two perspective, make a plan, share that plan with your patient, and you make that plan, your consultation a success. Okay, that is very important. Okay, so OSCE is all about finding out what needs to happen in a particular case and how will you make it happen in the next 10 minutes. Trust me, in the first minute, you have to decide what's going on here and what am I going to do, in which direction I'm going to move in the next 10 minutes. Right. So there are some top tips to pass your OSCE. A few tips, not all. So you don't have to put out an act for the examiner. Just act as naturally as you would. Focus entirely on your patient, on solving his problems. And please deal with your role play, your simulated patients, exactly the way you treat with your patients in your real life. Okay. So you don't have to set out a play, right? And the better you pay attention to your patient sooner, the better you are going to get the hang of it, that what is going on, the agenda of the case. In OSCE terms, we call the agenda of any case, right? So in the patient's part, you will be asking open questions, and open questions are the ones which doesn't have a clear yes or no answer, which requires an explanation. And don't rush into close-ended questions. Close-ended questions are the ones which have yes or no answers. So after the patient's part is done, you have to use open-ended questions in the patient's part. And when that part is done, your part begins, then you start using close-ended questions and you signpost before you start your close-ended questions, okay? And yes, please don't waste your time on the questions which would not add any value to your case management, okay? You're going to lose your time. Okay, so when you think that you're running out of time, so it is okay to take control, because sometimes you think that management is left and your patient is telling you the word. Okay, so it's okay to take control of your time, right? And you have to move on to your management plan no later than 4 to 5 minutes. And while you are giving your management plan to your patient, think aloud. Okay, whatever plan you're going, because you're not just telling that plan to your patient, you are telling that plan to the examiner as well. Okay, so sometimes you are short on time. You may, tell the patient that I would be discussing some lifestyle measures with you. There are some tablets to deal with your conditions, and there would be some red flags to look after while you are being seen in a hospital. So your examiner knows that you are going to talk about all those things, that you know those things, right? Lastly, please, this is very important, that whatever management plan you make for your patient, please incorporate patient's concerns. For example, your patient's main concern wasn't headache, his main concern was brain tumor. So in the management plan, you have to take his concern into consideration specifically, and again with inverted commas. You just cannot exclude the concerns of your patient in the management plan, no matter how well you have prescribed the medications for headaches or follow-up plan or safety net, or if you haven't included his concerns in your plan, you would lose a significant amount of marks, right? Okay, so I have extracted few slides from the main course, which I'm going to discuss here with you. So our session 1 would be on communication skills, the history taking skills. I have gone very rapidly through history taking skills in the first few slides today. However, it's not that simple, and I would break it down. So I've tried to simplify the history taking skills for you. So I have divided into two parts. The first half of the history taking, the consultation, and the second half of the consultation. So first half would be around 4-5. Don't take it as 5 minutes. It could be 4 or 5 minutes, or could be 3. Okay, but it must be less than 5 minutes. And there would be second half your consultation. So first 5 minutes of your consultation should include the greeting and introduction, opening and rapport building with your patient, the cues handling, the psychosocial impact, ideas, concerns, and expectations, and then you are going to get the data from the patient, that is history taking, and then you are going to give out a micro summary to your patient. Okay, and the second 5 minutes of your consultation, if you are done with your first part of the consultation in 3 minutes or 3.5 minutes, 3.3 minutes, you can move on to the second half. Okay, so it's not hard and fast. So when you're done with all those greeting, introduction, all those, then you can quickly move on to the next part, the second part of the consultation, which should include the examination where relevant, the investigations where appropriate, and a management plan, and a beautiful ending. And overall, you would be thinking of the multi-morbidity, the multiple diseases in your patient. You would also be considering polypharmacy. For example, an elderly patient comes to you with multiple tablets, okay, and with the falls, comes to you with falls. So you have to take into consideration the polypharmacy. You have to take into consideration fitness to fly and fitness to drive where appropriate, okay? And not to forget, you have to practice ethics in your consultation. Right. So first part would be as I would be discussing only three parts today: greeting and introduction, opening and rapport building, and cues handling. So first part is greeting and introduction. So welcome the patient by name. You would be given a document on your portal where you would be given the structure of your consultation, how it falls step by step, and useful phrases to say during that part of consultation. Okay. So how would you welcome? What phrase would you? Hello, Mr. Smith. Okay, and you introduce yourself, your name, your role in the general practice, and your body language is, of course, very important, which plays a very important role in rapport building. Okay, so let me show you an example. Dr. Adya, she will be assisting me to show you how you greet and introduce your patient. Okay, so Dr. Adya, I'll be the doctor, and please, will you be my patient, right?
Yes.
All right, all right. Okay. Hello, Mrs. Smith.
Hello, doctor.
I'm Dr. Sairaza, one of the GPs here. Okay, so what did I do? I said, hello, Mrs. Smith, and I waited. I paused for hello back. Okay, you don't have to rush into your greeting and introduction. Pause for the hello back. Okay, and then I introduced myself. It would take hardly 2 seconds. It's very important. And my body posture, you look at the body posture. Look at his eye contact, his open arms, his slightly leaning forward. This is all what is rapport building. It seems like he's fully interested, smile on his face. So it seems like he's fully interested in his patient. Okay. And then you open your consultation. Okay, just like you end your consultation beautifully, you open your consultation beautifully as well by saying, it's a universal phrase, how can I help you? Okay, so after you say that, there would be golden minute, in OSCE we call it the golden 1 minute, in which you let the patient narrate. You let the patient speak his heart out. You don't interrupt while you build the rapport. You pick up the cues. How would you pick up the cues? You nod. Mm-hmm. Okay. Right. 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 Oh, that must be difficult. Yeah. Okay. And when don't interrupt in that 1 minute. It could be 30 seconds, 40 seconds, 50 seconds. It could be up to 1 minute. This is called the golden 1 minute. Please let the patient narrate the story to you. And in this minute, you just build the rapport, pick up the cues, what the patient is trying to tell me, what the patient's main concerns are. What's the patient agenda is for today's consultation. Okay. And when the patient is done with his golden 1 minute, then you ask a follow-up question. Tell me what's been happening, or would you like to tell me more about it? Okay, so here's how you do it. Dr. Adia, I'll be the doctor. Okay. Hello, Mrs. Smith.
Hello, doctor.
I'm Dr. Saira as one of the GPs here. How can I help you today? Okay.
Doctor,
So
I
right, she's been telling me, okay, we don't have much time to spend 1 minute here. So, okay, I have kept silent. I've been listening. Mm-hmm. Right, right. Okay. So would you like to tell me more about it? Okay. So it's as simple as that, but that opening will score you full marks in your OSCE marking domain checklist because they are checking, they are ticking their checklist there. So for the opening and for the golden 1 minute, for the rapport building, there is a checklist. So this is the checklist I have segregated for just they have this RCGP, they have marking domain. I have just sorted all the points that they would be assessing you on just your opening, your rapport building, your greeting and introduction. It's RCGP words. Calls patient by name, pause for, by the way, I included this myself because I think it's absolutely necessary. So this is not by RCGP, this is by me. And if you are building a rapport, and how is your posture? It shouldn't be closed or leaning backward or very rigid posture or looking here and there. It's not a good practice. Okay, listening and actively, you seem interested, and you open the consultation. How may I help you today? And then you explore the main concerns with open-ended questions. And during those 1 minute, that 1 minute, you remain responsive. Okay, right. Okay. And you're led by the patient's responses. Right. Oh, you said something about headache. All right. Is it that? Oh, okay. So with the last word that your patient has uttered, you just follow up from there. Okay. Take it forward from there. So what is cue handling? It is very important, right? Uh, Actually, patients, they would, the simulated patients, they would give very, very obvious cues. There are two types of cues. There could be verbal cues and there could be non-verbal cues. Patient uh, with both hands on her head, what does it show you? That she is very depressed, very tense, like this patient. This is a cue. This is non-verbal cue. These are all non-verbal cues. This wheelchair is a non-verbal cue. Okay, if a patient comes to you on a wheelchair, you tell her, okay, in my notes, I see that you weren't on wheelchair when last time I saw you. Is it something new? And she would tell me, oh yeah, doctor, my disease, my condition has been worsened and I feel very weak in my legs now. So these cues, they help you navigate to your diagnostic information. They are that important. Okay. So you have to pick up those cues, right? So that is very important. And yes, I have extracted how in OSCE, they are going to assess you on picking up the cues. They would assess you on red, amber, or green, right? So whether you have identified the cues and whether you have clarified and explored the cues, just like I have clarified with the patient who came on a wheelchair, right? So today's main topic was transient ischemic attack. This is an extract from our real course. And I've extracted this particular topic, selected this topic for today's session. So first things first, what is transient ischemic attack? Basically, it's a temporary blockage of an artery in the brain by a clot, and it resolves within 24 hours. It gives symptoms, but it resolves within 24 hours. And what is the cause of transient ischemic attack? Of course, a blood clot. And that clot that plugs any small vessel in your brain, the oxygen is cut off for the time being for a few minutes, and the patient soon recovers. What's the treatment? Since the patient recovers, however, we refer this patient, but the whole treatment focus would be to for the GP to reduce the risk factors and to prevent that clot from happening again, right? And what are the risk factors for TIA? Well, age is a risk factor, very common after the age of 70 years. Whether the patient has high blood pressure, diabetes, atrial fibrillation. Atrial fibrillation forms a clot, fires up in your brain through your neck arteries or vertebral arteries into your brain, and there you go. If the patient had previous stroke or TIAs, the chances are higher. Myocardial infarction, or artificial heart valves. And if how is the lifestyle? Smokers, alcohol consumption who take more than the limited units, obesity, low physical activity, they all pose greater risk to TIAs, right? So where does the clot it come from? As I told you earlier, it comes from the neck vessel. So that is why we refer our patients, and definitely they undergo a Doppler scan for the neck veins, right? The neck vessels, basically. So mainly the carotid or the vertebral artery. So clot forms in the heart. due to atrial fibrillation or anything, it fires up through your neck arteries, neck vessels, and goes up into your brain. Okay. So what are the symptoms? So these are the symptoms. Patient may lose balance, may have changes in the vision, may have some weakness of the face, like facial nerve palsy, as we all know, may have weakness in one arm or both arm or leg weakness. There could be difficulty in speech. If there are symptoms like those, then it's time to call an ambulance. Okay, so it's called Be Fast, Be Fast, Be Fast, right? So this is the fast score which a GP can use in the clinic. However, it doesn't definitely tell if it's a TIA or stroke, because there could be overlapping symptoms with other conditions as well. But it gives you an idea that it is a likely candidate. You strong suspicion of TIA, and you have to refer it. You have to recognize it as an emergency. So this is what they roll out to their general public to remember: be fast. Loss of balance, eye changes, face drooping, arms or leg weakness, speech difficulty. If all of those or one of those or few of those are there, then it's time to call an ambulance immediately. So how would you assess this patient? You just look at the patient for the consciousness level. Okay, is it decreased or normal? You take the vital signs, the blood pressure, the pulse, the heart rate, rhythm, and ECG. Okay, and then you also ask for dysphagia and incontinence, and you do the neurological examination of all the cranial nerves. And by the way, cranial nerve examination takes hardly 30 to 40 seconds, and I'm going to show you how at the end of this session, right? Limb neuro examination, you check the tone, power, sensation, reflexes, and of course the gait. You have to check for the cardiac examination, listen to the heart sounds, any murmurs, carotid breeze, okay? And not to forget, it's a very good practice, would give you some extra marks if you perform capillary blood glucose tests at your clinic, or tell your examiner that I'm interested. I would be asking for that as well, because it's an overlapping with hypoglycemia symptoms as well. Right. So what are the tests which are usually advised after TIA suspicion? ECG. You check the rhythm, whether there's a patient is in atrial fibrillation. You check for full blood count, fasting glucose, because we are going to refer this patient anyway. Okay. So make sure that you advise all those tests as a baseline test. Urea electrolytes, LFTs, thyroid function test, liver function test, urea electrolytes. Echo, if the specialist thinks it's necessary, and color carotid Doppler also by specialist. Once the patient is, you will not ask your patient to wait in your clinic, because it's not your domain, carotid Doppler scan. Okay, so this is the explanation that we have to give in each case, every topic, each station to your patient. This is very important. I have designed explanation. I have formulated an explanation for all the topics which come in OSCE, about 200 topics, and I have written the explanation of each topic. So what is explanation? Explanation is 3 to 4 lines explanation in patient's terminology, jargon-free, simple language, and you have to memorize these explanation by heart. You would be having that explanation document on your portal. You make sure that you memorize those explanation, 3 to 4 like for TIA, for stroke, for myocardial infarction, for chronic heart failure, each and every topic. So when you are trying to give out an explanation to your patient right on the day of your exam, so you must be very fluent. Okay, so how would you explain TIA to your patient in a patient's language? Okay, so I think after examining you and after talking to you, I think the most likely cause of your condition is what we call TIA, transient ischemic attack. It's also called mini stroke. Have you got any idea about that? Oh, doctor, no. Oh, so basically there's a clot which may form in your heart, and it fires up to your brain through your neck pipes, and it plugs a small pipe in your brain, and it temporarily blocks the blood supply, hence the oxygen, and it is temporary. So as it explains that now you have recovered fully. Okay, so have you understood that? So this is how you give explanation, and you have to memorize these 3 or 4 lines for each and every topic. Okay. And it's a good practice to draw a diagram. It will score you million marks. Trust me on that. Just draw a simple diagram. I drew a diagram in one of my stations for autosomal dominant pattern of inheritance. And my examiner was very happy. I could see joy on her face. Okay, so it's a very good practice to draw a very rough diagram. It doesn't have to be picture perfect, artisty diagram. Just a basic diagram to show that this is the clot, this is called the blood pipe. Here is forms the clot, and here it plugs, and this is your brain. An examiner will be super happy with you. So these are the very important top tips that I would be sharing with you all during the course. So what is the treatment? Treatment would be medication at the GP clinic and reducing risk factor when the patient comes back to us after he's seen by the hospital. So two scenarios here. Patient comes to you and there are no ongoing symptoms. Patient is absolutely fine. You refer this patient, okay? Within 20. So today, this patient has to be seen by a stroke physician within 24 hours, and you give your patient 300 milligrams aspirin stat. However, there are some contraindications to giving aspirin. If aspirin is contraindicated for some reason, if your patient has blood disorder, you have to find that out. It will carry extra mark. Or if your patient is already on some newer anticoagulation for atrial fibrillation already, okay? Or if there has been more than one TIA, okay? So then you don't have to give aspirin. Okay, you just refer your patient right away. And if patient comes to you with ongoing symptom, actually today, this morning, I had the similar patient of TIA. She told me that she has difficulty swallowing. If she's trying to drink, it's drooling down from the left side of her mouth, and there's weakness on left side of her arm. And I just referred her right away. I just said the time is the only thing which matters at this point in time. Please don't waste your time here. You have to rush to the hospital. You have to rush. So this is by surprise. This was my topic for today's discussion. And just this morning, I had this case. Okay, so how would you follow up or safety net your patient? You would say that at the hospital, they would conduct a further test on your brain, could be MRI, could be CT. That's not your domain to decide whether it would be CT or MRI, but you would tell your patient that they would do a scan on your head and a jelly scan of your neck vessels, okay? And after you are done with the hospital management and you are back home, how about I see you next week in my clinic and we discuss about how to prevent further episodes, and I'll discuss the medications with you, right? And meanwhile, you safety net your patient. So meanwhile, till you are seen by the hospital staff, you get those symptoms again, please call emergency immediately from your phone. Okay, so this is how you safety net the patient as well. Also discuss about the driving during the history as well. Okay, have you driven to the surgery today? Okay, if the patient has, then you have to safety net your patient that would you ask someone to pick you up and take you to the hospital, or if he says or she says no, then how about I arrange an ambulance for you? Okay, so patient must not drive if the patient had single episode of TIA for a month, or if the patient had multiple TIAs, he must stop driving for at least 3 months. And when the patient comes to you next week after he's been seen by the hospital, given the medications and each and everything, then you discuss about the secondary prevention of all the risk factors that we have discussed, discuss with the support groups, the driving, that yes, further driving is still prohibited till 1 month. You assess the depression. It's very important. All these kind of diseases, conditions, they come with us. So you can use your PHQ-9 score or the key two questions. We are not going to go into detail of depression screen. And if the patient has something residual with the weakness of the arms or the legs or the speech, you consider sending your patient to the speech therapist, occupational therapist, physiotherapist, social services, okay? And not to forget, please, where applicable, please mention annual influenza vaccination in your TIA patient, right? Okay, so here's it is an ideal video. Okay, let me see if the sound is shareable to you. Share sound, right? So I'm going to play this video. I'm going to pause this video at certain interval to show you what she's trying, what she's doing in the history taking, okay? So let's begin.
Hello. My name is Dr. Muniappa. Is it Charles Mann?
Yes.
It's nice to meet you, Mr. Mann. How can I help you today?
So there she had done the opening. Okay, the opening, the greeting, the introduction, and the opening. Hello, Mr. Man. I'm Dr. Monia. And she paused for the hello back, and she did the opening. She said the opening phrase, "How can I help you today?" Okay.
I got up this morning and the left side of my arm and leg was really weak, and it only lasted for about 30 minutes, and I'm only here because my wife insisted that I told my nurse, because I came for my regular checkup for my diabetes, and she insisted I'd mentioned it to the nurse, and she said I should see you.
Right, okay. And how...
See, his golden 1 minute lasted for 40 seconds. You see the top right corner of the screen? His golden minute lasted for 40 seconds. She was, look at her posture, slightly leaning forward, open arms. She was nodding. She was smiling. She seemed interested. There was a good eye contact with the patient, and she didn't interrupt the patient. Okay. And then now she is going to ask you some open questions. So in the patient's part, you ask open questions.
How long ago do you think this happened?
About 4 hours ago.
4 hours ago, okay. And you feel fine now?
Yes, I do.
Yeah, okay. So you mentioned it was your left arm and your left leg that were weak. Were you able to get out of bed, or did it stop you doing that?
It stopped me for about 30 minutes or so.
Okay.
It was really difficult to move, and then it went off, and then I could move about okay.
Okay. Did you notice any other weakness, like in your face?
No, nothing, no.
Okay. Were you able to talk okay?
Yes,
Yeah.
yes.
Has this ever happened before to you?
Nothing like this at all before at all, no.
Okay. Did you have any chest pain at all at the time?
No.
And did you feel your heart racing at all?
Yes, that was racing.
Okay, and that happened at the time that you had the weakness?
Yes, it did.
Okay. And has this ever happened before?
Not at all.
Never. So it was just about 4 hours ago you woke up.
So what she has done now, after in the patient's part, she asked few open questions, and then she asked 5 or 6 closed-ended questions. Has it ever happened to you before? No. Your wife concerned? Yes. So closed-ended questions now. And now she is going to give a micro summary. It's a good practice. However, it's not necessary at this point in time, but she did a micro summary. Just watch.
Up. The left side was weak,
Yeah.
but you were able to talk okay.
Yes.
Were you able to see okay?
Yes, vision was fine,
No
nothing else.
problem. You mentioned that your wife was worried, and she's urged you to mention it to the nurse
Yes.
today. Was she worried about anything in particular? Were you worried about anything? Or...
No, I don't worry about that sort of thing, but it was my wife.
Did you have any ideas of what it could be?
No, not really. I'm just hoping that, you can just say everything's okay. I didn't really think anything of it.
Okay. And did you think I'd be doing any specific tests or any specific things when you came to see me today?
Well, probably just kind of a general examination of my heart and all that sort of thing.
Okay.
That's it.
Okay, that's fine.
So what she has done, she picked up one cue. What was the cue? She said, you said that your wife was concerned about all this. So could you tell me about it? And then she explored ideas, concerns, and expectations. Are you worried about anything in particular? Okay. So she opened the consultation. She greeted, introduced herself. She helloed the patient, waited for the hello back. Okay, then she asked the opening question, how may I help you today? Then there was a golden minute, which lasted in this case 30 seconds. And then she started to ask the open-ended questions. And then she entered into the doctor's part, where she asked the closed-ended question, to which the answers could be yes or no, right? And then she gave a micro summary. Then she picked up the cue, because she parked that cue in her head. Okay, then she asked the cue here. And then she explored ideas, concerns, and expectation. Okay, so that's still where she is now.
So if you wouldn't mind, I'm just going to ask you a few just general questions just about your general health and health.
Okay, so she said, if you don't mind, I would like to ask you a few general questions about your health, about the general condition. So what is it? it's signposting. Now she is shifting the focus of the consultation to from the history of presenting illness to the past medical history, past surgical history, drug history, allergy, family history, personal history. Okay, so she has signposted. She just did not abruptly ask those. So it's a good practice when you are navigating your history. Okay, it's just like driving a car. When you're navigating your history, you signpost when you're about to change the shift of focus of your question. All right? Okay, so observe now.
Things are at home. So we've got here that you suffer with diabetes.
Yes.
And you also have a high blood pressure.
Yes.
And you're on some tablets for that?
Yes, I take 2 for my diabetes and 2 for the high blood pressure.
Do you take any other medication from over the counter, any herbal tablets?
No.
No, okay. Are you allergic to anything?
No.
Okay. Is there any family history of any strokes or heart attacks that you're aware of?
Well, no. You see, I'm adopted, so I don't know.
Oh, right. So. Okay. Are you working at the moment, Mr. Mann?
No, I'm a retired teacher.
Okay.
And enjoying my retirement.
Oh, good. And you mentioned your wife, so do you live at home with your wife?
Yes.
Anyone else? Anyone?
She's fine, and yeah.
Yeah? She doesn't have any other medical problems?
No.
No. And anyone else at home with you and your wife?
No.
Okay. Do you smoke at all, Mr. Mann?
Not anymore. I used to,
Okay.
but not anymore.
That's good to hear that you've stopped.
Yeah.
How long?
Okay, so she also explored about whether there's support at home. Okay, is there anybody else other than your wife at home? So you have to explore whether there's support system in all the old age geriatric patients, that if there's any. So there's a complete different history. I would be giving you a document how to do the associated consultation. So in elderly patient, always ask about activities of daily living, and is there support at home? And have you noticed that when the patient said that he has quit smoking, she appreciated her. Okay, so make sure that if your patient tells you something positive about their health or some good change, you always appreciate, and trust me, it would give you heaps of marks. Okay, so these are the tips that would come along right from my experiences and all that experience and books and everything that I've collected so far. So they would keep popping up. All right, so she just appreciated the patient. So make sure that if your patient has done something very good about the health, you appreciate. That's what she done.
How long ago did you stop?
Oh, it's got to be about three years, but I used to smoke for about 20 years.
Okay.
And I used to smoke 20 a day.
Right.
So, but I thought enough is enough. So
you've stopped now?
I've stopped now,
Okay.
yes.
Do you drink any alcohol?
Oh, very, very little. I leave it to the weekends, and it's only a glass of wine or 2.
Okay, nothing more than that?
No.
And do you mind me asking if you drive?
Yes, I do.
Yeah, and how have you got here to the surgery?
That's how I got here today.
You've been driving. Okay, so just to make sure I've got everything right, one more time, it's the left side.
So here, when you're going to give out the summary, the micro summary, remember in the second slide of today's session, I have discussed that your greeting and introduction, rapport building, and then your data gathering. And then there is going to be the open-ended question, close-ended question. And by the end of it, by the end of doctor's part, when you are finishing doctor's part, the first half of your consultation, make sure here you give a micro summary, which should be around 20 to 30 seconds, okay, of the whole, so that you would know that you and your patient, we are on the same page. And you would also like to ask your patient, am I missing something? So it's a very good practice. It's, again, please keep writing those tips, because I didn't plan those tips for today's session, but somehow it keeps popping up in my mind. So I thought, why not give it away right then and there? So when you finish your summary, just ask your patient, am I missing something? Or would you like to add something to it? And if you have been missing something, important information or any cue, you would be able to grasp thought, or if you have missed out the agenda, your SP, your simulated patient would give you right there. So it's a very tricky question. It's a very, standardized question, just to make sure that you are on the right track in your consultation for that particular station. All right.
arm and leg that were weak this
Yes.
morning, happened about 4 hours ago. You're fine
Yes.
now, the symptoms have gone away.
Yes.
And your wife's really urged you to come in
Yes.
today to get it checked out.
Yes.
Okay, that's fine. So what I'd like to do now is examine you. I'd like
Right.
to start by checking your blood pressure again,
Okay.
just checking your pulse, checking the nerves in your arms and your legs, but also in your head, and having a look at the back of your eyes. Would that be okay?
Yes.
Right. So now she was moving her focus, she was navigating her consultation to the examination part. So she's signposted. So now I would like to examine you. I would be checking your blood pressure, listen to your heart, do your nerve examination of your face and your arms and legs, and listen to your heart. Okay. So that's how you explain what is going to happen in the next 1 minute to the patient. Okay, don't surprise the patient. Okay, just grab the patient and start listening to the heart or testing. Okay, signpost. That was the point I highlighted in one of my slides. You signpost whenever you are shifting the focus of your consultation. Please signpost it. That's what she did here. Okay, and you have to do it for real, right? Every station, wherever it's necessary, you have to examine your patient. It may take 30 seconds to 1 minute. It can't be more than that because you won't be having that much time. Okay, so your neuro examination would take hardly 30 seconds to 1 minute. Okay, that would cover the neuro of the cranial nerves and the limbs neuro, and listen to the heart. You are not supposed to check the blood pressure right there. You just act. Okay, I will act it out for you by the end of this session, and we'll see how you do it quickly in 30 seconds to 1 minute.
That's fine.
Okay. Okay, well, thank you for letting me examine you. All the checks that I've done today have come back okay, which is good. Okay.
So after the examination is over, please make it a note, write somewhere, thank the patient. You tell the patient that examination is over now. Thank you for letting me examine you. Please, you may put on your shirt back. And please, would you mind moving to the seat? Okay, and let the patient sit first, and then you sit after him. It's a courtesy which they would look for on your station. Okay, so yeah, and explain the exam. She explained the examination findings. Okay, so I've done the examination findings. They are quite reassuring, right?
However, I am concerned about the symptoms that you had earlier today. I think it could be something called a mini stroke.
Ooh.
Have you heard about mini strokes?
Well, not really. I've heard of.
So this was the explanation I spoke earlier. So after the examination, the data gathering and the examination, then you have some strong points to make. By this time now, you must have some working diagnosis in your head, and you have to explain that working diagnosis to your patient. Okay, so now you're going to explain to the patient in 3 to 4 lines in a language which is understandable to the patient, and that's what she's going to do.
Strokes, but not
Sure.
mini strokes.
So what do you know about strokes?
That it kind of paralyses people.
That's right.
And it affects your speech and how you think, and they improve, but it usually leaves people not what they used to be.
That's right. So you're absolutely right. That's what we class as a stroke. Now, a mini stroke is when you have a temporary interruption of the blood supply that goes up to your brain. And when you have a stroke, it's usually a permanent loss of that blood supply to certain parts of the brain, which is why you're left with weakness or symptoms that persist. But in your case, I think because it was temporary, all your symptoms have resolved and gone back to normal. But that's what we call a mini stroke. Okay. Mm-hmm. Now, mini strokes we do have to take seriously, and I would like you to have some checks done at the hospital.
Oh.
How would you feel about that? So that was a cue, and she picked up that cue, and now she is going to explore that cue, because now she's moving to the management plan. She's navigating again. She's changing the focus of her consultation to the management plan now. Okay, and there comes another cue which she picked up right there, and now she's going to explore it.
Ooh, I'm a bit worried about going to the hospital.
Okay.
Yeah, Yeah.
Was there anything you were worried about in particular?
No, it's just everything that goes on around you, really.
Okay, okay. Well, it is a necessary part because we need to get some certain tests done,
Okay.
including some more specific blood tests and also a scan done of your head so that we can see if there's any evidence of these issues with the blood supply.
Okay.
Okay.
Yeah.
Now, I would also like for you to have a tablet today, something called aspirin, just to help thin your blood until you see the hospital. Would that be okay?
Yes, yes.
So we'll
Okay, so she just rolled out a management plan for the patient that I need you to be seen by the hospital, and I'm going to give you a tablet called aspirin that actually thins the blood. Okay, she explained the function of that medication. So I'm going to talk about when you are prescribing a medication, what points you are going to tell your patient. So she said she just told the mechanism of action or what it's going to do. And then she said, is that okay? And this approach is called chunk and check approach. You give patients small chunks and then you check. Is that okay? Would you be able to do that? Is that fine? Are you getting me? Okay, so during your management plan, you use chunk and check approach, and that's what she's doing. And it is very important. It makes sure that your patient is happy with the plan. He is able to comply with this plan. And that's what we call patient-centered approach, okay?
We'll get that for you at the end of the consultation.
All right.
Now, I'm going to make a call to the hospital and ask for them to see you. So you'll be seen today in the
Oh,
hospital.
today?
Yeah.
Oh, right.
Is that going to be okay with you?
Yes, yes.
Yeah. Now, the only other thing I would say.
So she chunked and checked again. Is that going to be okay for you if you are going to be seen by a hospital? And he said yes. So she's been constantly chunk and checking. Chunk and checking. Chunk means small sections and then checking if it's okay. If it's okay, can you do that? Are you happy with that? Okay, so that's very important.
Is because I think it has been a mini stroke that you've experienced. We usually say you can't drive or you shouldn't be driving for at least a month or at least until you've seen the hospital.
I love driving.
It is just for safety purposes because in the first month you're at more risk of having a further one of these, and if for some reason it happened whilst you were driving, it can cause an accident.
Yes.
And you can hurt yourself as well as other people.
Yes,
so
yeah.
we say at least for the first month. If you go up to the hospital and the consultant says otherwise, then that's fine, but the usual advice is for a month.
Okay.
Okay. Now, we do need to get you up to hospital for the appointment today. Is there somebody that could take you?
My wife, as long as she can get here, she can drive me, yes.
Okay, that's great.
So she did the safety net here. He said, you are not allowed to drive for a month and I wouldn't allow you to drive to the hospital. Is there someone who can pick you and take you to the hospital? But she sugarcoated it. She said in words which were acceptable to the patient. However, patient posed some resistance, some reluctance that he loved driving, but she somehow managed it. So how you are handling those challenges during your consultation would also score you good marks.
Great. Now, just some advice. If this happens again before you get up to the hospital, so there's weakness in your face, any problems with your speech, any problems seeing, or weakness as you described this morning, I would like for you to call 999. It's likely the appointment is going to be sometime today, but I will confirm that with the hospital.
And if that happens when I'm at home, it's a 999 call.
999 call, just because we need.
So it's very important to safety net your patient and make sure that they have the emergency contacts number. Do you have the emergency contacts in case you get those symptoms? Please call emergency services. You have the emergency services number with you. So this sentence would be sufficient. This phrase would be sufficient for the examiner to know that you have got your management plan sorted, right?
To get you checked ASAP.
All right.
Okay.
Thank you.
Now, would you like some information about mini strokes?
Yes, I would really. It's kind of been a bit of a shock, really.
Sure. Okay, I can see that. So I'll print out some information for you.
Yes.
I'll make the arrangements at the hospital. So if you want to take a seat in the waiting room, I'll let you know.
So giving out informational resources to the patient, there's a way of doing it. You just don't grab a printout and just place it in patient's hand and tell him to read it out when he's home. You have to create a value of those educational resources. Say, how about I just ask, always ask, don't impose anything on the patient. How about I give you some information leaflets so that you would be able to know what's been going on, and you may have few questions about it. So then when next week I see you, we would be able to I would be able to answer your questions that pops up in your head, and your wife would be able to know what's going on with you. How about that? And the patient would definitely say yes, because now you have created a value to that information resource. Okay, as compared to the one in which you just ordered, okay, take the print and go home, give it a read. Okay, patient would just throw it in the bin on your way out of your clinic or the hospital, right? So add value to that information resource. That's what she did.
Know when that appointment's going to be.
Thank you.
The information that I'm going to give, it may be worth as well sharing to your wife, so if she recognises these symptoms as well,
yes,
that she'll know what to do.
All right,
Is
thank
that
you.
okay?
Yes.
Do you have any questions at the moment?
No, it's just take.
Right. Once you have rolled out the management plan to her patient, chunked and checked, and she safety netted, follow-ups, referral plan, she invited the questions right at the end. Do you have any questions for me, or do you like to ask me anything? Okay.
Taking it all in, really.
Sure.
I probably would have when I think about it, but
Yeah.
not just at the moment. Thank you.
If you do come up with any questions, if you just write them down, and I'll make an appointment to see you next week, as long
All
as
right.
there's no other problems in the meantime.
Okay.
So you can see the hospital, see what they say, and then we can maybe have a chat next week.
All right, thank you.
Is that okay?
That's fine.
So I'll make those arrangements. Just have a seat in the waiting room.
Thank you.
Thank you very much. Thank you.
Okay, so it would have been a good practice. I would add from myself that it would have been even better if she would have asked her patient, so could you recap that plan, so that I would know that you have got everything right in your head. And your SP would, recap quickly the management plan if you have time. Otherwise, that consultation was sufficient to get you a clear pass with flying colors. Okay, so now we have Q&A, and after we have, let me show the neurological examination before we move on to Q&A. Okay, let me just unblur my. Okay, so I have got Mr. Smith right behind me, right? So we are going to go for the examination of neurological examination, which you could do in like 30 seconds. Okay, the arm is missing. I'm going to get the arm. All right, so suppose that this is the arm of the patient. Sorry about that. So this is the arm of the patient, right? So I would say, now I'm going to, Mrs. Smith, now I would like to examine you. I will be checking your pulse, your blood pressure, and I'll be testing your nerves and listening to your heart, okay? Will that be okay? Okay. Quickly, I would, just put hands on his arm, okay, not for whole 1 minute, but just to see the examiner that you are getting the examination right. Okay, and then feel for his upper arm. Okay, I would like to have get your blood pressure checked, and the examiner would give you the findings of the blood pressure measurement. Okay, and then you would go for the neurological examination. Okay, so first, how would you do examination in 30 seconds? Eyes, nose, mouth, side of the face, shoulders, and then arms, and then legs. Okay, and then we will come to the heart part. Okay, so look at me. Are you able to see me? Are you able to see me? Okay, so look at my hands. Okay, follow my hands, finger. Okay. Okay, could you place your finger on your nose and then my finger? Okay, right. Okay, good. Don't let me open your eyes, screw your eyes. Okay, frown. Okay, show me your teeth, blow out, say ah, push my hand, Okay, shrug your shoulders. All right, all right. And then you would test for the arms, okay? You see? And then you would ask the patient to, flex his hands and ask, don't let me push, don't let me pull. Okay, please close your eyes. Can you feel it here? The sensations, okay? And then you're going to check the reflexes, okay? And then, okay, Mrs. Smith, would you able to show me to walk for me few steps? Okay, can you walk on your toes? Can you walk on your heels? Can you walk on a straight line? Would you lie down for me, please? Okay, once the patient lies down for you, you check again the power, okay? Let the patient fold his knees and don't push the lower leg, and then make the patient push against or pull against your force, and then check the reflexes there and check the sensations there as well. Okay. And could you sit down and take off your shirt, please, so that I would listen to your heart. All right. So once the patient takes off his shirt, you listen. So you have to be on the right side, right? And you listen to the heart. So this examination must be in 30 seconds, right? Just to show the examiner. Okay. Okay, I'm going to put my step on your neck. Right. Okay, the examination is over. You may cover yourself. Thank you for letting me examine you. Please move back to the seat. Okay, so that's how quickly you do it. No later than 30 to 40 seconds, because you won't be having that much time there, right? Okay. Okay, I think we have to let Mr. Smith go. And during the session, you would be role playing with me and we would be practicing right there. Okay, for each case, there wouldn't be any separate examination sessions, because see, you are going to manage a particular case, and do the examination relevant to that case. So we would make sure that the examination which would be focused and relevant to that particular topic, you must learn that only, instead of learning loads of information, PLAB level or AMC level examination, and you won't be able to practice it in your 10-minute station. Okay, so we will be very practical in our examination training stations. Okay, right. So there would be Q&A for the participants. Would you please, Dr. Adia or Dr. Iba, unmute the participants so I would take the questions. Yes, so do we have questions in the chat box? Empathy is also very important. I'm going to discuss empathy as we go along. Very, very well, very good point raised, Fairy. Yes, you have to show empathy at each and every point. During the golden 1 minute, when you are building rapport with your patient, and the patient tells you something, when my father died last year. Oh, I'm so sorry to hear about that. It must be very difficult for you. So these phrases I've collected 4-5 phrases for each expression that you have to show in your exam. I've collected those, made a document, and I would put it on your portal, so you don't have to, make up those phrases on spot. So you can go through these. We are going to practice those phrases during our 12 weeks consult session, and I would want each one of you to be fluent. So this would not be just OSCE, to pass OSCE course. It would be confidence building course as well. It would be your consultation skills building course as well. Okay, so, and it would be your communication skills, your English skills. I would want you to be very fluent in the English, because that's the one most important problem that I think most of the participants face. So that is one course fits all. So I would try that you would be very fluent in English by the time we are done with the 12 sessions. Very fluent, very confident, and you everything is on your tips, the explanations, the empathy, the expressions. So it would flow from your mouth, instead of thinking in your head, then in Urdu or in whatever language you have, your first language, and then converting it in English and then telling it to your patient. So I want each one of you to be very fluent. Management plan means I have to tell the examination verbally. No, the management plans covers mostly, the management plan starts after the doctor's patient's part, and it's the second half of the consultation. And the plan must contain the explanation of the condition, the investigations, okay, and pharmacological, non-pharmacological, referral, follow-ups, a brilliant goodbye, safety netting. So that's the management plan. The examination is before that. Examination is not management. It's a way of reaching your working diagnosis. Okay, so it's before 5 minutes part. Okay, unable to see you. Someone said, all right. So are the participants unmute? Do we have questions? Maybe I should. Dr. Ariba, Dr. Adia, are we unmute? Have you unmuted the participants?
Assalamu alaikum, doctor.
All right, okay.
Hello.
Sorry. I think I have lost my Bluetooth somewhere. Yes. So do we have questions?
Hello.
Yeah. Now I can hear. Sorry, it was
Am
my
I
bad.
audible?
Yeah, you are. Yeah. Hello.
Okay. Assalamu alaikum. My
Welcome,
name is
Sam.
Dr. Shafqat, and thank you so much for the fruitful presentation you have given us
You're welcome.
ahead of our exams. So my question to you is that you said you will be starting your courses in November, right? 2024?
Yeah, that's right. Yeah, that's right.
Okay.
1st November 2024. Yeah.
I'm appearing in October, so it will be. Hopefully I pass my exam in October. So anyways, if you are going to give any more free sessions which are
Yes,
like this,
yes,
I will be happy to register in those also,
definitely.
so that we
Definitely.
get an idea and
Yeah,
how to appear. Thank you
yeah.
so much.
Thanks.
I have not yet started studying. I think
Yeah,
I'm getting late. I should be
yeah,
doing it.
yeah,
But
yeah.
yes, today your session was little bit boosted for me. Wake up.
Yeah, yeah. That's what it's all
Okay.
about. Yeah. So, Dr. Ariba, would you take a note of that query, please? And I'll make sure that we have more free sessions coming up. Okay. Anyone else?
Thank you.
Yeah.
Yeah.
Again,
Hello.
I'm Dr.
Hello, Dr. Shafqat.
Ashkar.
All right.
Yeah.
Yeah.
In fact, I'm also planning to give on this October. I would appreciate if you could put more, sessions.
Free sessions.
in
Yeah.
between.
Sure.
Very good.
Sure.
Yeah.
Yeah. We'll definitely plan. Please, Dr. Ariba, please take a note. Yeah. Any other questions from the participants? I would love to answer. All right. I think there were any questions about today's topic, TIA? Yeah, Dr.
Assalamu
Amreen.
alaikum.
Welcome, Salam.
I want to ask, while taking the history
Yeah.
as same in the video, they were asking the smoking and alcohol question same as I'm asking you some questions about your lifestyle, or we have to ask it by giving another signpost, like do I have to ask do I ask some personal questions from you? Is that okay? Could we use the word personal, or we have to ask the smoking and alcohol questions in the lifestyle changes?
Okay, the less signpost you do, the more time you have for the real questions. Okay, if you signpost before asking the family history, if you signpost before asking the personal questions like alcohol, smoking, you would lose your time. So how about you just signpost once? Now I'm going to ask you some specific questions, general, about your general health and your lifestyle and your family history. Is that okay with you? So one signpost, and it would cover everything after history of presenting illness. It would cover the past medical, past surgical, drug history, allergies, and the personal history like lifestyle, support, if you need to inquire about support, if you need to inquire about mental health or depression, and yeah, things like that. And then you're going to give the micro summary. Yeah.
We can ask travel history also in the one signpost.
Travel history, where relevant, yes, you have to ask travel history if it's required for that particular scenario.
Okay. Okay. Thank
Yeah.
you. Thank you, doctor.
Yeah.
Thank you so much.
Thanks.
Thank you
Thanks, Dr. Marine.
session. And
Dr.
I'm
Saira, there is one question in the chat box.
Okay, let me see. Can you provide details about the registration process and the cost of the course? Do you provide the preparation course for MRCGP written exam? Okay, so the written exam queries have been overwhelming, but after I'm done with the OSCE course, I'm definitely planning on the AKT for MRCGP. Yes, definitely. And the registration links would be sent out. Everything is on the website, Please, could you please write the emergencyfocus.net info@emergencyfocus.net in the chat box and pin it. Please send in your queries about the course details, the registration process, and cost of the course. It would be sent to you. Okay, right. Any other query? So do we have any other query? Your course is for coming MRCGP February. Yes, I'm targeting MRCGP for February. But as few participants today have suggested that we should have more free sessions like those, so I would definitely have more such sessions for you. No problem for me. Definitely. So those who would be attempting in November would be able to benefit. So it's August, September, and October. So there's 6 weeks more to go for them. All right. info@emergencyfocus.net. Yes, it's in the chat box. Please pin your message, Dr. Iba. So if you have any particular query about this course, upcoming course on November, which is going to launch on 1st November 2024, please send in your queries at info@emergencyfocus.net. 2 times. Total duration of classes, yes, it's going to be 2 sessions, Mondays and Wednesdays. And it will start on 1st November 2024. Yeah. What will be the duration of the class? Okay. So today's session duration, I told my team, okay, I will wrap up today's session in 40 minutes. And my team said, Dr. Saira, forget it. Trust me, you won't be able to complete this session in 40 minutes. And how long has this session been going on for? I think more than 120 minutes. So I would say that, yes, the session would be 3 hours, but till I think the topics have been covered, that session would continue. Yes. Yes, so it's not very hard and fast, but 3 hours minimum, one session. Any other questions? No questions for anyone?
Dr. Sahira.
Yeah.
Dr. Shafqat with you again. So
Yeah.
with your experience for the October exam, like how should we start? I mean, I've not started yet. And how do you suggest me to start, and how many cases per day should I go, practice with myself? I don't have a study partner as well.
Right.
If
so
you are,
when is your exam? On October 16th?
It will be 19th October.
So it's roughly about 10 weeks.
Yeah.
Yeah. So start practicing from today and start practicing at least 6 to 10 cases from today, from day one. Have a study buddy and start practicing. See, this is where you have to take this exam. This was the very first point that I've told you today, that please take this exam very seriously, because it has got a very good investment. You are going to put in a hefty investment into it. Investment, not just financially, but your efforts, but your time, your family. You have to put your family at stake. The whole family. It's a whole family exam. So it requires a lot of lot of your time. So the better you practice and pass it in one go, so the merrier it is. Okay, so to save you from again going to the same stress again, God forbid. So practice, start
Thank
practicing.
you so much.
Yeah.
Thank you.
Oh, okay. So any other questions? Right. I think we don't have any more questions for today. I'm so sorry for the question before asking, but when I enrolled for PLAB 2 in UK, why bias towards Indians? Could you please reassure me that it is a non-biased study session here? I'm a huge admirer of Dr. Rizwan. Again, sorry for the questions. No worries. Uh, uh, today, have you noticed anything biased against someone? So it would be a friendly session, and you will enjoy. I'll try my best that everybody just pass it in first attempt. Okay, so no bias there. Right. So I think we are going to wrap it up. Send in us your queries, and we are going to send you the course details. Okay, thank you very much, everyone, for your participation again. And it was lovely meeting you all. And hopefully we'll meet again next month. All right, with another free session. Goodbye.